Hi, this is Dermcast TV, and we're coming to you from San Diego. It's the Summer STPA Conference 2024. I'm Douglas DiRuggiero, and I'm a physician assistant that practices dermatology in Rome, Georgia.
I'm Jenny Shao, and I'm an associate professor of dermatology at the University of Southern California. So today we're going to be talking a bit about GPP and what it means for patients to have this condition, and also have a few examples of cases that we're going to be discussing through. So just to kick us off, can you tell us a little bit about what you think about the course of GPP?
Well, I think really the first point is that GPP, generalized pustular psoriasis, we're finding out really isn't psoriasis. Obviously, there's overlap and crosstalk between these two diseases, but it may be something that we can't just say that this is psoriasis that has some pustules. This is actually a different disease and therefore has a different impact, a different course than we see with our normal psoriasis patients. So your question is, how does it really present itself? Well, it can present itself in a lot of different ways. I mean, the new onset can be acute and it can be severe. You know, that's the patients that we learn about when you first get into dermatology. This is one of your potential life-threatening disorders, right? And in that case, this is a disease where people come in with flu-like symptoms, fever, they have arthralgias, they feel like a train's hit them, they have skin pain, and then they can have that presentation of this bright red or coral erythematous background with small pustules or lakes of pustules. They can have other psoriatic presentations too, you know, things that we do see in psoriasis. That's where the overlap. They can have nail changes, they can have small plaques that are scattered throughout. So I think it's a disease that in its acute phase can often be missed. We know that's the case. But the key, what we're talking about today, is that it can be chronic. And this is a chronic inflammatory disease. When the flare subsides, what's the patient living with during that time period? And because their symptoms don't go away, the quality of life doesn't go back to where it was before the onset of this disease. So it is a disease that's got this sinusoidal curve that just goes throughout, where we have to make the right diagnosis, not miss it, and then we have to hang with them after that to make them realize and educate them that there are other things that are going to be happening in between, and how can we help you get the best quality of life kind of in between. I don't know if you've seen that in the patients you've seen. Not that we see a lot of patients with this.
Yeah, it certainly is a rare condition, but we do see these patients. And when I think about GPP, I go back to my derm residency, where it's like it's an emergency, right? Like the patient is in the hospital. So I always thought about it in that sort of acute care setting. But it's so true. These patients leave the hospital. They still have symptoms, they still need management. And so I think shifting my view of GPP from being like just in that hospital setting to this is a chronic inflammatory condition that requires, management beyond what happens during the flare phase, given the chronic burden of symptoms, thinking about it from that perspective, almost like I think about my HS patients, right? We have those periods of flare where they're calling, trying to get in the office, but even beyond those times of flare, I want to make sure I'm managing them because they have symptoms during their baseline time period as well.
Yeah, I think sometimes I've missed, over my career, as I look over my shoulder, I've missed the diagnosis of GPP because I have a patient that presented with more psoriatic type symptoms. They weren't in that acute hospitalized flare, right? And I've put them on a therapy for that, a psoriasis, therapy, whatever that therapy is. And they may come in with a little bit of some pustulation that's around their plaques. And I think it's easy to interpret that as maybe medicine failure. They've been on this for a couple of years, it was working great, or they've been on it for 6 months, it's working great. Now it seems like I'm getting these flares. And I think maybe the tendency is maybe we need to change therapies. We got so many choices now, so many great choices for treating psoriasis, without really putting on the thinking cap and saying, maybe this isn't just psoriasis and I'm not hitting the right target on my diagnosis. So I think it's important for us as NPs and PAs who don't have that hospital exposure and are training as much as you guys do. We aren't rounding hospitals now because of hospitalists, but we're the ones who may get a phone call from the ER doc saying, I got something strange here, or from the urgent care, colleague that's on the other side of town. So I think it's important for us to have that mindset of like counseling that colleague on the phone, ask these questions. What are you really seeing? Don't let them miss it and just send them out the door with steroids, right? And am I missing it when I'm thinking it's just psoriasis flare, but it's not just regular plaque psoriasis. It is this different entity all in of itself.
Absolutely, completely agree.
Yeah. Well, let's look at some cases that I think may help us guide our discussion and maybe help educate some of our colleagues on not just the acute phase, but also living with it kind of in between these acute phases.
All right, so it looks like we have a 50-year-old woman. She's got a 25-year history of GPP. Her GPP, I think one thing to note is GPP can also present differently on different skin tones, and so we always are looking for erythema as an indicator of, oh, there's inflammation activity, but on darker skin tones it may be more subtle or even look a little more violaceous, so really important for us to keep that in mind. And her last GPP flare was about a year ago, but it resolved. But she does still experience these chronic skin symptoms, so there's still pain, there's still itch, she has some erythema and scaling, and she also complains that, she just feels tired. She just doesn't feel well and sometimes has difficulty just going about her day. And I feel like one point to make is a lot of times patients may not come to us telling us these things, right? So it could have been something that we probed to ask about. So in a case like this, what are some other considerations you might have in terms of other management questions or things to sort of probe on to come up with a plan for her?
Yeah, this is a great scenario to talk through. I think the point is to don't just be led by your eyes, which is what we're trained to do. We're in dermatology. It's easy to walk in the room and look at them and say, you look like you're doing great, and not give them the opportunity to really say what's happening in their lives, because you can look good on the outside but have a lot of stuff going on the inside. So I think the key is asking those probing questions. Does your skin hurt? Are you having any joint pain? What's your energy level? What kind of things are you doing or avoiding because of having GPP? This is a patient that's already been diagnosed with it. They had a flare a year ago, so we're assuming we've got the right diagnosis, right? And so I like to ask them, is there anything that you wish you could do in your life right now that this disease is keeping you from doing? So I think it is just kind of being willing to sit down, be at their level, look them in the eye, and tell them, look, I want you to know that patients who have this disease, when you've come off a flare, it's been a year ago, but that doesn't mean that you're not still living with symptoms. And I want you to tell me if you think anything is still going on, and just let them fill in the blank.
Yeah, I completely agree. I feel like, sometimes you can be really surprised by the answers that you get just based on objectively looking. It just doesn't look like, that there'd be that many symptoms associated because they look completely different from how they did look when you, let's say, saw them in the hospital, right? But still that impact on quality of life, also just with the anticipatory anxiety about another flare coming. Depression symptoms are also highly reported in this group of patients. So I think another targeted way that we could try to screen for that is also, if there's time, there's a 2-item questionnaire, the Patient Health Questionnaire 2. You can download it for free, and it's 2 questions. The patient can fill it out, and it's scored from 0 to 6. If it's 3 or higher, there's a really high chance they have depression, and should be referred for further workup, like primary care doctor or behavioral health, just to let them know, there are higher rates of these types of feelings among patients with GPP, and we want to make sure that we're caring for all of you, right? Not just how your skin looks.
I think that's a very important point, because particularly if the patient on new onset or their last flare was pretty significant and they were in the hospital, imagine the fear you have of ending up back in the hospital. So I think that fear of what tomorrow will bring is very, very real in this disease. And that's even, I think, kind of a point of education for them, to educate them and say, we may not understand it fully, but we know that this disease can sometimes be triggered by things like a bad sunburn, or you don't want to be on steroids for other reasons, because sometimes that steroid withdrawal can precipitate things. There may be certain medications that we are more prone to use as opposed to others that are known to be triggers for this. And so I think sometimes we can help them with that fear, anxiety, and depression by giving them some power, and that power is educating them on these are things you should be cautious with, so that it decreases your likelihood of potentially getting into another flare situation itself.
Yeah, and with that piece of patient education, I think it's letting them know, because it could have been that they thought that there were only treatments available when they had flare, because that's what they had experienced, right? In the hospital, all of a sudden they were getting all of these treatments being thrown at them. So
do you ask your patients what they have at home and what they're using?
Absolutely. I mean, we've seen those Ziploc baggies, right? Filled with multiple different tubes that they'll bring in to show us.
Yeah, I think that's an important piece too, to say, are you looking great? I'm not talking about feeling great, but are you looking great because you're just using a moisturizer and your skin is stable? We can look at the skin and the skin looks normal, but is there any information out there that tells us what's actually happening in the skin in someone who's not currently in a flare and who looks to us to be fairly clear?
Yeah, and I think that's a very interesting question, because we think about inflammation as always being reflected in the skin in terms of how it looks, but this is not always the case, right? And so when we looked at patients not in an active flare and looked at their skin and inflammatory markers, even though the area sampled, again, was almost clear skin, inflammatory markers were still elevated. And I think that really goes to show that chronic smoldering inflammation that's still present and can explain some of the symptoms that GPP patients have in between flares, where they're saying that their skin still doesn't feel good, there's still pain, there's still itch. And the other thing of note too is, when we look at the slide here, we can see that the DLQI at baseline for these patients, 16, 10, these are high numbers, right? 11 or higher, it's having a very large effect on the patient's quality of life. And again, they are not in flare at this point. And so I think that really tells us as clinicians that it's our job to inquire about how they're doing between flares and to know about the impact that GPP is still having on their quality of life.
So we've kind of talked about maybe some of the symptoms they're having, living between flares. But let's look at a second case and see if this case can kind of help us tease out some of, not just the physical manifestations, but a little bit of a deeper dive on some of those psychosocial or mental or quality of life indicators. So this is a 45-year-old male. He's currently on disability due to his GPP. So he's been living with this, right, for a long time. He experiences chronic skin symptoms and lives in fear of the next flare, which we see as common with this. Often experiencing episodes of anxiety and depression, so that's there, right? And states that there are occasions in which he has trouble with his daily activities. All right, so I think that this is a pretty real scenario that someone who's living with this. So what do you do with a patient like this? They've been living with it, they're on disability, they admit that they're having problems. How can we quantify those problems? How can we help them verbalize those problems? How do we follow those kind of problems?
Yeah. I think I really liked that question you threw out earlier, asking a patient what has GPP prevented them from doing that they wanted to do. And in this case, it's very clear. He's on disability. Yeah. He clearly is suffering from anxiety, depression, and is able to verbalize that. I think that, really assessing impact on quality of life is important. We talked about the DLQI earlier, and if able to administer, I think it's a really helpful way of sort of having patients on their own circle numbers, and they don't have to sort of verbalize and tell you, and then you can work off of the numbers that you're seeing to really probe deeper. But even just a one question like, over the past 7 days, how much do you think having GPP has influenced your quality of life, and allowing them to sort of use their own words to come back at you, I think is helpful. Right. And hopefully help him get from a place where he has a lot of anxiety and fear regarding flares, he's still not feeling well overall, to feeling better and going a longer period of time where he hasn't had a flare, and be able to sort of hopefully adjust to a better new reality where he's not always in the shadow of a life-threatening flare about to happen just around the corner.
Right. And we know at the kind of the tail end of last year, we finally got a publication from the National Psoriasis Foundation about kind of a consensus on how to manage GPP, but it focused on the acute flare. And what's missing from that is how to manage the time in between what we're talking about, what you're talking about. So I think it's good for us to hear from the experts like you and hear from each other on how we're really making those questions. In terms of depression and anxiety, are you personally managing that, or do you make sure that all these patients are in consultation with their psychiatrist or a psychologist? And are you probing into that side specifically if they're admitting to having those symptoms? How do you handle that in your office?
Yeah, so I think of myself as someone who sort of on the dermatology side, we can be helpful in terms of screening for these things. So I think screening for depression is something we absolutely are able to do, but I'm not an expert at managing depression. So I think it's helpful to know, like, is the patient plugged in with a good primary care doctor, right? So there are actions and steps you can take after you've done like a quick screen with a PHQ-2, for example, or let's say the patient's just saying they have depression type symptoms. What can we do? We can tell them to go to their primary care doctor to talk about it, or even send that primary care doctor a note Like, please, next time you see this patient, assess their mood. We can refer to behavioral health. We can provide different mental health resources. And if there's any hint that you think the patient may actually have, for example, suicidal ideation or tendencies like that, if you're going to screen in the office and they admit to it, being ready to send them to the hospital, potentially for urgent admission, or providing them with a number for the National Suicide Hotline. So I think those are the things we can do in order to help in terms of managing and screening for those depression type symptoms.
Yeah, I think the message to our primary care, emergency room, urgent care colleagues is that this is a disease that really should be managed and followed by a skin specialist, by folks in dermatology. But that makes us just a great gatekeeper of asking the right questions, identifying symptoms, and then anytime I feel like that we have a multi-system chronic relapsing, disease, it takes a village to really help people reach their maximum potential with what they're living with, and so I think that's a great point to make, that we need to be reaching out to our colleagues who have expertise in occupational therapy, home health, whatever their needs social work and anxiety management, depression management, and so I think that's important for folks listening to this to say, hey, this is your time. This is not something you want to silo yourself and manage this kind of disease, because patients need more than that. So, any other things that you would want with this particular patient to ask them about? I mean, we talked about doing a DLQI. Some offices will do that, some won't. Even if you don't perform a DLQI, I think someone should print the DLQI out if you're not familiar with it and just read the questions that are on it. Because even if you don't hand it, put it in their hands and have them circle it, I think that the questions that are there are really good questions. You may not think about how you want to ask things, because it talks about it. Does it affect, your intimacy in relationships? Does it affect relationships you have with your family? Does it affect your ability to get up in the morning? Does it affect your ability to, to general physical activities? And so some of those questions can even guide the questions that we ask. Obviously, best case scenario, and with my GPP patients, I do a DLQI. It's the only scenario. I don't do it with all my psoriasis patients. I don't do full DLQI with my atopic dermatitis patients. We ask about, how's your sleep at night? How much are you itching? We have our own little set of our own little mini DLQIs that we put together. But in this diagnosis, it's worth the printout, in my opinion, to really have hard numbers, and it makes them think about a very specific set of 10 questions that they have to go through and rank. And so I think it's important. Do you use anything else?
I mentioned DLQI, PHQ-2, those are sort of my go-tos, and I think that it can really help you in terms of screening for depression. And for the DLQI, again, being surprised by a high number when you wouldn't have expected it, and perhaps encouraging you and the patient to have more discussion around management in between those flare periods and what optimal management would look like. So I think with a GPP patient sitting in front of me for a follow-up visit, we check their skin, of course, right? Signs of erythema, any pustules, any scale. Go in for those directed skin targeted questions like, itch, pain, but then also the systemic symptoms, fatigue, malaise. And then third, really thinking about that quality of life, which we've given lots of examples of sort of questions you can use. And DLQI, I think, would be optimal if you have the time. And even just having it printed out, it's at the front desk. You train your front desk staff, hey, if a patient has a diagnosis of certain things like GPP, just go ahead and hand them a DLQI, fill it out in the waiting room. It doesn't take away from clinic time. And then fourth, thinking about that depression component, really trying to make sure we're addressing their mental health as well. So I think with those sort of components to your visit, you can feel armed and ready to go to make sure you're addressing sort of all aspects of their condition in a targeted way to help you guys come up with a plan in a timely manner.
Excellent points, as well as making sure that if you have prescribed something that you feel like it's going to help them, are they getting it? Is it coming to them? Are they getting it from the pharmacy or the specialty pharmacy? Are they using it in all those different areas as well? Because that unfortunately, that component of compliance and access is something that we can never fully walk away from either.
Oh, absolutely. I mean, there's nothing more disappointing to me than when a patient comes back 3 months after I've seen them, for example, and they didn't even, the medication never made it to their hands. So letting the patient know, if you're having difficulty accessing what I prescribed, please let us know. Don't wait till your next appointment before bringing it up.
Yeah, excellent. Well, Dr. Schall, this has been an excellent discussion. I can't thank you enough for being here, being with Dermcast TV, being in San Diego at the SDPA conference, and just giving your time and expertise to help educate me, educate my colleagues on how to handle this rare disorder. Even though GPP is rare, it doesn't mean we don't have to be aware of the ways to help patients, question patients, and not miss the diagnosis. So thank you very much for being here.
Thank you for having me.
Thanks.